Welcome. My name is Chris Starr. I'm from Weill Cornell Medical Center. I'm with Preeya Gupta, my friend and colleague from the Duke Medical Center. This, of course, is going to be a multidisciplinary approach to the diagnosis and treatment of chronic dry eye disease. And this activity is actually supported by an educational grant from Allergan, so I want to thank Allergan for this as well. The learning objectives for this 1-hour session are many: to identify the signs, symptoms, and risk factors associated with dry eye disease, to apply traditional and newly developed tools to accurately diagnose dry eye disease, to discuss the full treatment armamentarium for dry eye, including the recent developments in prescription therapies, and to design a multifaceted treatment plan to advise patients on the management. Okay, good. So let's get started with the first section, which I'm going to give. I'm going to talk about dry eye disease, the burden, the prevalence, and the pathophysiology. And a lot of what I'm going to talk about really does come from the TFOS DEWS 2 report, which I'm certain most of you are familiar with. This was sort of a seminal publication that really came out just a few months ago, so it's really brand new, hot off the presses. For those who don't know, TFOS stands for Tear Film and Ocular Surface Society. DEWS is the Dry Eye Workshop. This 2 is the second one. There was one in 2007. It was the TFOS DEWS 1, the first of its kind. Massive literature review. And someone might ask the question, well, why do we need another DEWS in just 10 years? And the answer is that the literature in the dry eye space has literally doubled in the last 10 years. Everything that came before 2007, and in the last 10 years, that has actually doubled. So there's been an explosion, a boom in this understanding. This is why we have a full house at 7:30 in the morning. On a Monday at the Academy. So there's a lot of interest in this, a lot of explosive new work, a lot of people very much interested in this, a lot of exciting things in treatments and diagnostics and understanding. So we'll cover a lot of that here today. The DEWS process, it was a 2-year process. In 2015, they began recruiting. It was a worldwide initiative. 150 different experts from around the world were included. Preeya and I were both honored to be part of the DEWS committees. And 23 countries were represented, and it was published, as I said, in July of 2017. So again, very, very new, exciting stuff. So what really did change in the last 10 years? Well, of course, there's a lot. The original report was about 100 pages, and this one, I think, was about 400 pages. So there's a lot of new information here. One of the things that people get talked most about, the thing that is cited the most, almost every single podium talk from 2007 to 2017, every article cited the DEWS definition of dry eye, the definition. And if you didn't read those 400 pages, everybody knows the definition and has heard it many times. The definition as it was in 2007 was dry eye is a multifactorial disease of the tears and ocular surface that results in symptoms of discomfort, visual disturbance, and tear film instability with potential damage to the ocular surface, and it is accompanied by increased osmolarity of the tear film and inflammation of the ocular surface. And it was important for a number of reasons, but one of the big reasons why this was such an important definition was that it was the first definition that included the word disease. Dry eye is a disease. But for the 2017, the DEWS 2, there was a lot of talk about, well, should we change the definition? And 77% of the DEWS subcommittees and members thought, yes, it should be changed, but what to change it to was open to a lot of debate and a lot of back and forth. Enforced questioning, there was a lot of support from the DEWS members that it should be simplified, that definition was too long, too complicated. It needed to be evidence-based, so in fact the definition was one of the last things that was done in the DEWS after the 2 years of research and evidence-based research, literature reviews, et cetera, et cetera, et cetera. A definition did come out in September of 2016 at the TFOS meeting, which is there on the slide. It was much simplified, it took out things like inflammation, and osmolarity, and that became the source of a lot of debate and a lot of back and forth, and so a lot of people were not happy with that definition. And so the final published definition of dry eye, this is the current one, this is the one that you should all be aware of, as based on the DEWS 2. Dry eye is a multifactorial disease of the ocular surface characterized by a loss of homeostasis. That is the key concept here in all of what we're going to talk about today. A loss of homeostasis of the tear film and it's accompanied by ocular symptoms in which tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities play etiological roles. This is a little bit of a busy slide here, but I can tell you that each word in that definition was scrutinized and debated and discussed, and each word does have significance. As I said, homeostasis is a big new concept in this whole realm, something that you want to familiarize yourself. Homeostasis describes the state of equilibrium in the body with respect to its various functions. Another big change in this new definition was it said accompanied by ocular symptoms. In the original one, it had very specific symptoms, but we realized that when you look at, we want to make dry eye disease, we want it to be sort of standardized amongst all countries, all regions, all ethnicities and regions, languages, and cultures. And so they purposely took out a lot of those symptoms that were in the original definition to respect that. And then etiological roles, things like hyperosmolarity, inflammation that are in the definition are not necessarily outcome measures. You don't necessarily have to have all of those things to call it dry eye disease, and that's why the word etiologic roles was in there. Let's talk a little bit about epidemiology. This is a worldwide disease, of course, and interestingly, the prevalence is higher in Asian populations, higher than in Caucasian populations. We don't have a lot of information about the Southern Hemisphere because actually in the last 10 years there has been exactly zero population-based studies in the Southern Hemisphere. Accurate reporting of the prevalence of dry eye across regions and epidemiologic studies is very difficult. TFOS and the DEWS-2 tried to do a meta-analysis of the literature, and quite frankly, it's very hard when you're looking at various studies that compare apples to oranges to bananas. They're not all standardized, and this is a part of the mission of the DEWS-2 was to kind of hopefully standardize some of the outcomes, some of the reporting measures so that we're all on the same page worldwide so that we can get better data on prevalence. The meta-analysis in the DEWS-2 says, well, it could be anywhere from 5 to 30% worldwide prevalence of dry eye disease. Interestingly, MGD, which is the biggest subset of dry eye disease, was evaluated in 5 large studies, and the prevalence ranged from 30 to about 68% worldwide. And we do know that the prevalence increases linearly as we get older. One of the very consistent risk factors. This is one of your questions in the beginning, the pretest questions. What are the consistent risk factors? Which consistent, i.e., the strongest evidence to support these risk factors? Female sex, older age, increase in almost every single study. So those are probably the most consistent, most well-known risk factors. Other consistent risk factors, MGD. I think we're all on the same page that MGD is one of the number 1 risks for dry eye disease. Hematopoietic stem cell transplantation is a big one. Computer use. This is leading probably to some of the increased prevalence that we're seeing in younger people who spend a lot of time on computers. Asian race, as I mentioned. Contact lens wearers, well-known. Sjögren syndrome and other autoimmune diseases, of course, increase the risk of dry eye. Androgen deficiency as we get older. Hormone replacement therapy. Environmental conditions, pollution, low humidity environments. And, of course, medications. Systemic medications, antihistamines, antidepressants, anxiolytics, and retinoin all increase the risk of dry eye disease by various mechanisms. Probable risk factors. So the evidence is not as strong, but it's pretty good. Diabetes, rosacea, viral infections, thyroid disease, psychiatric conditions, pterygia, low fatty acid intake, refractive surgery like laser vision correction, LASIK, and allergic conjunctivitis all have strong associations with dry eye disease. And then for the inconclusive, there's some evidence, but it's not as strong as the other 2 categories. Hispanic ethnicity, menopause, acne, sarcoid, smoking, alcohol, pregnancy, Demodex, interestingly, Demodex infestation, Botox, multivitamins, and oral contraceptives. So lots of potential risk factors for dry eye. Part of this talk was to discuss the burden. The economic burden of dry eye, as you can imagine, is high. Very sometimes hard to put a number on it, though. And this is a quote taken directly from the DEWS report, the economic burden on society and the impact of dry eye on the individual through its detrimental effect on vision, quality of life, and work productivity, as well as the psychological and physical impact of pain, are considerable. And they are considerable, especially if you probably have if you're a dry eye sufferer, you have personal experience with this. The most significant costs are indirect costs due to reduced work productivity, and there have been many studies that looked at this directly and put a number, a dollar sign on that, and it's substantial, in the billions of dollars a year. This is also a somewhat busy slide, but this is a new subsection of the DEWS report on sex, gender, and hormones, which, as we learn more and more about it, this is becoming more and more apparent. Sex and gender are two different things in the medical literature. Sex is based on a biological characteristic, but gender is more based on a socially constructed set of characteristics ascribed to each sex. The female sex is a known risk factor for the development of dry eye, as I said, across many, many studies worldwide. This is partially due to androgen deficiency as we get older. That, of course, occurs in both men and women, but women start off with less of it. But there are also anatomic differences that account for this. The female gender, interestingly, the stereotypical gender role of women is associated with a greater willingness to report pain, whereas the expected stereotypical masculine role in society is more of a stoic role. So that leads to differences in reporting of pain and symptoms and things like that. And so the DEWS recommends take this into account the best that you can when you're treating men and women for dry eye disease. This is something that I found to be very interesting. This is new information about the tear film. You know, we've always thought of the tear film as a 3-layered tear film, right? There's lipid on top, there's aqueous in the middle, and then you've got mucin coating the epithelial cells of the ocular surface. Well, that has now changed, according to the DEWS report. It's a 2-layered tear film. There is still the very fine lipid layer on top. It comes exclusively from the Meibomian glands, and we always thought of that as being the primary driver against evaporation. That's still probably true, but it doesn't prevent as much of the evaporation as you probably once thought. It's not 100% for sure, and in some studies it's as low as even 10%. And then the second layer, the thickest layer, is what's now called the mucoaqueous layer. It's a mix of mucin and aqueous. So it's not two distinct layers. And the mucin is mixed in. Yes, the concentrations of mucin decrease a bit as you go more anterior, but it's mixed in throughout that whole layer. So it's a 2-layered system now, which I found to be very interesting. Pain and sensation is becoming more and more apparent. We're learning more and more about the role of corneal nerves and pain sensation in ocular surface disease and dry eye disease. There are 2 types of pain. There's neuropathic and there's nociceptive. Neuropathic pain, which many of you have probably heard of by various terms, neuralgia being one, pain without stain is another descriptor of this. And that describes a lesion of the somatosensory system which may lead to the perception of pain in the absence of clinical objective signs. You have a patient who's in front of you. My eyes are driving me crazy. They burn. They're electrical shocks. And you look at them and their ocular surface of their corneas look pristine, perfect tear lake, normal tear breakup time, no staining at all. What is that? Well, that's probably a neuropathic disorder, and this is a quote from the DEWS report, it is not pathophysiologically caused by dry eye disease, nor should it be diagnosed or treated as such. And the treatment for these neuropathic disorders is oral systemic medications, such as like the anticonvulsants, tricyclic antidepressants, opioids, and neuromodulators. Gabapentin is a big one that people use, diclofenac. Some studies look at autologous serum and even amniotic membrane as being somewhat effective, but these are smaller studies. And confocal microscopy is actually now being looked at as a source for making some diagnoses of these types of things. These are hard to diagnose. This is also, a lot of times it's a diagnosis of exclusion to call something neuropathic. And it's hard for ophthalmologists to sort of get on board with that thinking. Nociceptive pain is more what we think of when we think of eye pain, true eye pain from dry eye disease. It refers to an actual or threatened damage to surface tissue. There are various thermoreceptors, nociceptors in the cornea, polymodal nociceptors, and cold thermoreceptors. Interestingly, the cold thermoreceptors, which only make up about 10 to 15% of them, do respond to changes in temperature and changes in osmolarity. Again, the tie-in with osmolarity. As the osmolarity changes, temperature changes on the ocular surface, right on the epithelium, and that can trigger these receptors to trigger pain. When you look at a lot of the big studies on dry eye disease, especially in aqueous deficient dry eye disease, in the studies in which they measured corneal sensation with an aesthesiometer like a Cochet-Bonnet, you had found that in most of those studies, the corneal sensation ultimately does decrease when you measure it with a filament. And as I mentioned, the confocal microscope. How many people here actually have confocal microscopes in their offices and use them routinely? One person. Okay, so this is emerging. This maybe the next time we give this talk, maybe more of the hands will go up. We have one in our office, but we've always used it for looking at endothelial cell counts and things like that. But now we are starting to adapt it in these patients where we think, maybe there is a neuropathic issue here. Maybe there is an abnormality of the corneal nerves. And in that picture there on the bottom right, those are some of the sort of classic, well, I wouldn't say classic, this is all new, but the findings that one might find in an abnormal cornea with abnormal corneal nerves, extra tortuosity of the nerves, little neuromas on the nerves, and beating of the nerves are all sort of almost pathognomonic. If you read the DEWS report, the first DEWS report, you saw a slide like this, what's called the vicious circle of self-perpetuating inflammation. And this is sort of the key pathophysiologic sort of cycle that's common to all forms of dry eye disease. Hyperosmolarity, of course, is the driver. This is why it's in the definition. And that's often caused by excessive evaporation. As we know, evaporative dry eye is the most common form of dry eye rather than pure aqueous deficient. And it all leads to this sort of vicious circle of self-perpetuating inflammation that leads to more tear film instability. Tear film instability leads to more hyperosmolarity, and so on and so forth until you break that cycle. What's interesting about this graphic is that there are multiple entry points. When the periphery of that graph, it's all various entry points into this vicious cycle. Everything from MGD to Sjögren syndrome to LASIK, contact lens wear, vitamin deficiencies, so on and so forth. All of the classic risk factors that we talked about before all filter into this common vicious circle. And it all leads to a loss of homeostasis. Again, this idea of homeostasis being crucial, in the definition, but just crucial to the way we think about dry eye disease and really ocular surface diseases in general. And it all leads to worsening hyperosmolarity and worsening inflammation. Another interesting new concept that came out of this DEWS report, the TFOS DEWS 2, was that all dry eye ultimately becomes evaporative. We used to think, okay, there's aqueous deficient or it's evaporative. Which one is it? Pick one and treat it. But now we're learning that these two conditions exist more on a continuum. That it's very rarely is it one purely evaporative or one purely aqueous deficient, and often it's a hybrid. Another new term, hybrid dry eye. But even purely aqueous deficient, say from a Sjögren's syndrome, that will, as the disease progresses and as that inflammation cycles through and through and through, it will become evaporative. Tear breakup time will decrease. So that's a very interesting concept. This is a slide on MGD. Of course, it's the number one cause of evaporative dry eye. There are two forms of MGD that result in low delivery of meibum and thus increased evaporation. There's cicatricial and there's non-cicatricial. A key event in non-cicatricial MGD is hyperkeratinization of the terminal ducts, which leads to duct obstruction, duct dilatation, and disuse, atrophy, and death, basically, of these glands. And you can a lot of times see this on meibography. In cicatricial MGD, conjunctival scarring drags the meibomian orifices, terminal ducts, and the mucocutaneous junction posteriorly, drags it across the posterior lid onto the tarsal plate where the narrowed and displaced ducts can no longer effectively deliver that meibum to the tear film in the ocular surface, again leading to evaporation. Another chapter of the DEWS report was iatrogenic dry eye. We cause dry eye. A lot of things that we do as doctors induce dry eye or exacerbate pre-existing dry eye. Systemic medications I mentioned earlier. And interestingly, when you look at the top 100 best-selling systemic drugs in 2009, a quarter of them basically cause dry eye disease. So we do this day in and day out with our prescriptions and our over-the-counter medications. NSAIDs and analgesics, anti-allergic medications, anti-hypertensive medications, anti-ulcer, hormone replacement therapy have all been associated with dry eye. And it can cause dry eye by multiple factors. Topical medications, no surprise to anybody in this room that our glaucoma medications and virtually anything that you prescribe at high doses on a daily chronic basis that has preservative in it will probably cause some ocular surface toxicity. Many studies have shown switching to preservative-free improves the ocular surface. BAK is the big one here, of course. It's toxic and pro-inflammatory effects and has detergent properties, all of which can lead to ocular surface toxicity, breakdown of the epithelium and the tear film. But ocular surgery is another big one. Ocular surgery, we are learning more and more about the effect of our incisions on the corneal nerves, LASIK being a big one. Cataract surgery, though, is also very important in this, especially as expectations rise in the cataract surgical realm, as multifocal and extended depth of focus and trifocal lenses become more and more popular and expectations go up and out-of-pocket costs increase. This is becoming more and more of an important issue, addressing the ocular surface before cataract surgery and after cataract surgery. To lead into Preeya's talk, the DEWs did provide this. This is what they're calling a classification algorithm for dry eye disease. In its basic form, patients show up to the office. They either have symptoms or they don't have symptoms. They either have signs or no signs, and there's a basket of signs and symptoms and signs, and sort of a rough rubric on how to approach those patients. If they have symptoms with signs, then they probably have dry eye disease or some other form of ocular surface disease. Symptoms without signs, well, that could be neuropathic. We talked about this. Pain without stain. I've got pain, but you don't see it on the eye exam. Similarly, signs without symptoms could be the sign of neurotrophic disease, where their cornea, they're not sensing the surface changes, but you see overwhelming signs on the exam. So with that, I will pass on the baton here to Preeya Gupta. Thank you.
Thanks, Chris. I agree with everything that Chris said, except for that one sentence that said that men had a higher pain threshold than women. You may have not been surveying the ones that have given birth to a child. So we're going to be talking about the diagnostic and testing component. So Chris, excellent job. I think that it's hard to make the classification and risk factors an exciting topic, but it really is exciting. There's so much more that we know today in terms of what impacts our patients and who are the people that are getting dry eye. But we know that there's many forms of ocular surface disease, so dry eye is not the only one. And there's a number of conditions that sound a lot like dry eye, but we know that not all foreign body sensation and redness is dry eye, and not all dry eye patients complain of symptoms. And so for a long time, there was a gap between what we actually could see clinically and what we could diagnose. And so there really was a need for an objective set of tests that we could use to help in our diagnosis. So we're going to go over a couple of different types of tests here. So first, screening patients for dry eye does not have to be difficult. Two easy options are patient questionnaires. How many of you use a questionnaire currently? Good, so a lot of you. And then point of care testing. There are several questionnaires in the literature. According to the DEWS-2 diagnostic algorithm, they recommend using either the OSDI or the DEQ-5. And they chose those two questionnaires because they have the most validation in the literature. But I feel like there's so much to be learned from any of these questionnaires. And just the act of giving a patient a questionnaire or having your technician administer the questionnaire, it means that you're paying attention and screening for these patients. So all of these are standardly available. Some are a lot longer than others. This is a busy slide, but you can see the DEQ-5 is very short. It's just 5 questions. The OSDI has 12 questions, and you can access both of these online. This is the SPEED 2 questionnaire. The SPEED questionnaire in general is a little bit more sensitive towards MGD, so this is also a commonly used one in practice. So let's shift over to point of care testing. So our standard kind of more traditional tests like Schirmer's and things like that they're very outdated. And I really don't routinely perform Schirmer's because I find that it rarely gives me information that's going to have me treat patients and differently. And so our modern point of care tests have really revolutionized how we diagnose dry eye. It's allowed for us to gather objective data. I often refer to some of these tests as our ocular vital signs. So we have kind of a snapshot in time of how the surface is behaving, kind of analogous to our blood pressure, height, weight, kind of like when you go to see your primary care doctor. And I find that these tests allow for an earlier diagnosis of dry eye disease. And to me, that's the most important. After treating dry eye patients for a number of years, I found that treating them early is much more successful than treating them late in the disease process. And the last bullet on here I think is also really important. I find that these tests help me identify the masqueraders of dry eye. So we've all seen patients that come in and maybe they've seen 2 or 3 doctors and been diagnosed with dry eye, told to take some artificial tears, but really they don't have dry eye, they have recurrent erosions, or they have SLK, or chronic conjunctivitis. And so it's important to have your antenna up to look for these other ocular surface diseases. So here's a list of the tests that we're going to go through. So MMP-9 to test for inflammation, osmolarity testing to look for screen for hyperosmolarity, lipid layer and Meibomian gland assessment with the LipidView device, allergy testing with the doctor's allergy formula test, and then a novel modern test for Sjögren's disease. By the way, you guys, there's about 6 chairs here and 6 chairs there. Life is too short to stand, so feel free to filter it if you want. So let's start with osmolarity testing. I'm sure a lot of you are familiar with this test at this point, but it's a office-based point-of-care test, and it uses electrical impedance to measure the tear osmolarity. The device is very small. It's a handheld. You can see in the image below. The tear sample is just 50 nanoliters, so very small tear sample, very little disruption of the tear film when you're taking this test. The little chip is applied to the lateral canthal area, and then the device is inserted into the reader, and within a few seconds you get the device, you get the readout. It is a CLIA wave test. In terms of its interpretation, so anything that's 307 or less I consider to be normal. However, if it's 308 or above, or if there's more than an 8 milliosmol per liter difference between each eye, that is highly suggestive of dry eye disease. I think it's really important if you're doing a test to understand its sensitivity and specificity. Osmolarity is a highly specific test. So if the test is normal, there's a very high chance that they don't have dry eye disease. That doesn't mean they don't have something else, but so be looking for those other things, but it's less likely that they have dry eye disease. The other thing that's important to realize is that patients with dry eye disease, so they've done studies where they look at normals versus dry eye patients. Patients with dry eye have an extremely variable osmolarity. So you might test them one day and it's 290, and the next time it's 320, and the next time it's another number. And that in itself is highly indicative of dry eye disease. So there is some value in testing patients over time. One of the limitations of osmolarity is it doesn't sort of tell you, okay, it's this disease, it's aqueous deficient or it's evaporative disease. So in the setting of, as we talked about, if there is a normal osmolarity, what else am I thinking about? So these are the masqueraders. Maybe there's ABMD, SLK, floppy eyelids, conjunctival chalasis, mucus fishing syndrome. And so those are other things that I kind of think of on my list. So let's go on to the MMP-9 test. So we're all very familiar with MMP-9. If we go back to the med school days, I feel like that's the one inflammatory marker I probably remember. But it's kind of a late sign of inflammation. So it's patients that have, as Chris showed, that vicious cycle of inflammation, hyperosmolarity that drives that persistent inflammation. So if patients have gone through the inflammatory cycle, that vicious cycle enough times, there will be an elevated MMP-9 on the surface. So this is also a point of care test. It takes about 10 minutes to develop. It takes about 30 seconds to do the test. And it has a 85% sensitivity and 94% specificity, and is also CLIA waived. You can see in the image there's a little kind of test stick, and then that is applied against the bulbar conjunctiva. And the way it does this is it's an immunoassay. So you directly sample from the bulbar conjunctiva. It goes in a reagent, and within 10 minutes it develops a line. Any pink is positive, so the intensity of the color just shows you, it's not a quantitative test, so it doesn't tell you the exact number, but the higher the saturation of the color of pink, the more positive it is. So in our clinic, we say that any pink means that it's positive. So positive, pink line means positive, means elevated MMP-9, but what does that tell you? So for me, it actually helps to kind of, if I think the patient has dry eye disease and I see a very positive test, it sort of helps me guide some of my treatment. I might be more apt to put the patient on a topical steroid or a chronic anti-inflammatory agent. It also, in the setting of, for example, a normal osmolarity but an elevated MMP-9, tells me to look for other conditions. Certainly patients with recurrent erosions or ABMD can have that pro-inflammatory state, SLK. And particularly in my dry eye patients, and I don't know that there's necessarily a study on this, but I find that my Sjögren's patients, Chris, I don't know, are you seeing that? My Sjögren's patients tend to have very high inflammation, which naturally you'd expect. It's an inflammatory disease, autoimmune disease, but that's also, so if they don't have a diagnosis of Sjögren's, I might, think to test for that. So let's move on to the lipid layer. This is the Meibomian glands, the lipid layer, are critical to the maintenance of the ocular surface. The LipiView 2 device can actually perform lipid layer interferometry. So what this does is it measures the lipid layer thickness. If the lipid layer thickness is less than 60 nanometers, it has a 90% specificity for MGD. The one thing with this test I'll caution you is that patients can throw the test, meaning let's say if the patient rubbed their eyes or squeezed really hard right before you did the test, so they might still have MGD, but they just expressed a bunch of oil into their tear film. So I think it's helpful, but certainly not absolute. Meibomian gland imaging is one of my favorite point-of-care tests. It's one of the few tests that actually changes what I do clinically. It uses adaptive transillumination to provide kind of this HD, high-definition image of the Meibomian glands. And what I find it to be most useful for is patient education. So a lot of times patients don't understand MGD. They don't understand where the glands are. They think when you're talking about a gland, you're talking about the tear gland. And so the patients are very receptive to this image. But clinically, what it does for me is it helps me to stratify disease. I would say that as clinicians, we're notoriously poor at being able to identify whether or not there's going to be someone with extensive atrophy. Several times in my own clinical practice, I've looked at patients and pushed on the orifice, seen some oil flow, and said, okay, they're probably not, they don't have notching, they don't have posterior dragging, so they probably don't have extensive atrophy. And I've seen patients with that bottom image come in. And so I really think that it helps to set the correct expectations of the patient. A lot of times people will ask me, well, okay, I did therapy X, why are they still symptomatic? Or I put them on 4 treatments, why are they still symptomatic? And it often can be because they're just at a more severe stage than we realize. And so if you have access to a test like this, that can help you to uncover why someone is more uncomfortable. Allergy testing, so this is an FDA-approved test. It's called the doctor's allergy formula. It takes 3 minutes to do, and there's a panel of 60 allergens that are specific to the region that you're living in. So I think that's very, very neat that they can customize that. And within 15 minutes, the results will develop. They actually give a several-page printout to help patients kind of navigate, what can they avoid, how can they change their daily lifestyle to avoid some of these allergens. And allergy is, I live in North Carolina, and allergy is a big part of our year, pretty much all year round. And so a lot of the ocular surface patients are also allergy patients. Sjögren, so this is, go back 15, 20 years, you said dry eye and people just thought, oh, it's, I'm sure they have Sjögren's disease. And we know over time that a lot of patients don't have Sjögren's disease, but this is one of those diseases that you really can't miss, right? There's association with lymphoma and other systemic diseases, and if you can make that diagnosis earlier, that patient, it might have implication for treatment for those other conditions. I don't usually change how I treat my dry eye patients based on the fact that they have Sjögren's or don't. But systemically, I think it is very important. Our traditional markers, in our serum tests are the SSA and SSB antibodies. And the Sjö Test includes not only those traditional markers, but 4 novel markers that help to diagnose Sjögren's disease a whole lot earlier. So in summary, point of care testing allows us to make a rapid and earlier diagnosis. I think that it's very easy to include within your clinical practice. I don't think you need to have all of them. I would pick one test and kind of incorporate that and make small steps and small changes, and you'll sort of see how it impacts your practice. So we're going to shift over to the treatment. And I really think that because we're better at diagnosing dry eye disease, we're more actively treating it. And I think that the modern approach is to look at it holistically. We're not just talking about aqueous deficiency and evaporative. We're really, using all of these treatments to try to support the entire ocular surface. And so I really don't think treating dry eye disease has to be difficult. There's several therapies, and if you ever, the DEWS 2 report is available to everybody, free access online. They have almost like an encyclopedia of all of these treatments, and so if you want that, I think that treatment section, there's a table that lists all those. That's a very efficient way to get this information. But I think that knowing what's out there is important, but always customizing things to your patient. And to me, in general, I tend to take a stepwise approach, and I like to know what's working and what's not working. And by stepwise, I don't mean that, I'm going to start with artificial tears and then go to something more. It means I'm picking one therapy and then escalating from there. So I've divided them into 3 categories. So over-the-counter treatments, which we're all likely familiar with, topical medications, and what I call disease-modifying procedures. So over-the-counter therapies, this can be for anybody at any level of dry eye disease. So your typical tears, compresses, lid scrubs, lubricating ointments, omega-3 supplementation. And I try to find out, I tell them, give them all the tools, but I try to figure out, which one's going to be the most helpful? So is there a component of nocturnal lag? Do they have a poor blink reflex? Well, maybe they're sleeping with their eyelids open at night, and so an ointment might be something that I say, okay, out of all of these, just make sure you do this one. Do they have that crusty anterior blepharitis? If that's the case, then I might be more particular about saying, try to do a lid scrub. There's several that are commercially available. Can also recommend baby shampoo. But certainly, just the act of cleaning the lids in those anterior blepharitis patients, I think, is helpful. Artificial tears, in my patient population, it's a very polarizing discussion because, there's patients that swear, this tear is so much better than this tear, and it highlights the fact that it's such an individual personal preference. So I actually tell them, go to the drugstore. Here's a list of 5 or 7 of them. Go to the drugstore and figure out which one you like. Use it regularly if you find it to be helpful. But I try not to give them the homework that says you have to do the artificial tear and you have to do this, because the reality of it is that patients aren't going to be as compliant with these over-the-counter therapies if they have more than very mild disease. So we talked about these. Okay, omega-3. So lots of my patients ask me, what sort of nutritional things can I be doing? Probably omega-3s have the most support from the literature. And there's a study that was published. There's a randomized double-blinded 6-month trial of twice daily omega-3s versus placebo, and there was significant improvement in the symptom score and increase in the tear breakup time. And that's reflective of the fact that the omega-3s help to kind of thin the secretion of the Meibomian glands. In addition to the thinning of the secretion, there's anti-inflammatory effects. There's thoughts that there's lacrimal gland support as well. And not only does it have effect on the dry eye, but the systemic effects are also quite impressive. So in the cardiology world, the triglycerides and also just your cardiac health will improve with omega-3s. I believe in the orthopedic literature as well, there's some thought that it helps with osteoarthritis and joint lubrication. So let's go on to the anti-inflammatory therapy. So there's 3 that I listed here. So topical cyclosporine, topical Lifitegrast, and then topical steroids. So starting with the steroids. So steroids just blanketly suppress all inflammation. And so, we are all very used to putting patients on steroids. Sometimes we pulse them. Sometimes we use them for episodic dry eye. But one of the limitations is that, of course, there's some risk with IOP elevation and cataract formation, infectious risk in our contact lens wearers. And so we don't love the idea of putting patients on steroids or allowing them to use it kind of all year long. And so that's, to me, where these other two molecules really shine because they help you to spare the amount of steroids that you're using. So topical cyclosporine has been around since about 2000, and it inhibits the T cell activation to decrease inflammatory cytokines. And in its studies, it's been shown to increase tear production and goblet cell density, which correlates to improved corneal staining. Topical Lifitegrast is the newest player to the market. It was FDA approved last year, and it's an LFA1 antagonist. So it blocks the interaction of ICAM to the ocular surface tissues. And so it inhibits not only the activation of the T cells, but also the recruitment of the T cells. And it is the first drug to be FDA approved for both the signs and the symptoms of dry eye disease. This is the cyclosporine clinical data, just showing you that there was an increase in Schirmer's at the 6-month mark, as well as the 3-month mark. The Lifitegrast data, so this is only for one of the trials, but there was actually 4 trials as well as a 1-year safety study. In 2 out of the 4 trials, there was actually an improvement in the signs and symptoms of dry eye as early as 2 weeks. So I think clinically, in my own personal experience, I noticed that Lifitegrast tends to work a little bit sooner than the cyclosporine, but I think they're both excellent drugs. Certainly with any new drug, there's insurance coverage issues, and so for my Medicare population, I've still kind of stuck with the cyclosporine because for a lot of them, the cost is prohibitive in that population. So let's talk about antimicrobials. Oral tetracycline, so this is like doxycycline, minocycline. So they have kind of a dual mechanism of action. So one, it can help to decrease the bacterial lid flora. But when I think of it, I really am using it as also an anti-inflammatory. It helps to decrease the load of the inflammatory cytokines. And if you look in the literature, people use this at all different doses, 20 milligrams, 40 milligrams. There's the sustained release, 50 milligrams once a day, twice a day, 100 milligrams. So to me, I generally like to start, if I think there's a large infectious component, I might do like the therapeutic dose at 100 BID. But for my typical MGD, dry eye patients, I'm doing the 50 milligrams once a day. There can be significant side effects. I live in the southeast. There's lots of sun for most of the year. Skin sensitivity, phototoxicity can be a real issue in those patients that spend a lot of time outdoors. And then, of course, the chronic antibiotic use, upset stomach, the potential for bacterial resistance as well. So really, I like to reserve the doxycycline for my patients that are very MGD heavy or rosacea heavy, that maybe have facial rosacea. I think it can have synergistic effects there, but often my patients are not as accepting of being on an antibiotic chronically. Autologous serum, I put this in here because, of course, there's a spectrum of dry eye disease, and everything that I've mentioned so far, you can use it from anywhere from mild to severe disease. Autologous serum, so this is where typically a lab will draw several tubes of blood. They'll spin it down. They'll take the serum, which has the anti-inflammatory and kind of growth type factors that help to support the ocular surface and make it a friendlier environment to promote healing. I generally, just because of logistics, cost, I generally reserve this only for my very severe patients, maybe the ones that have chronic keratitis. I've also used it in some of my, chronic high symptom patients, and some of them improve. There is a product, I didn't put it in here, but that I'm using more recently. It's called amniotic cytokine extract. It's made by a company called Ocular Science, and I found that to be more beneficial even than serum tears. It contains a lot of the anti-inflammatories that benefits from amniotic tissue, but it's an acellular product, and patients use it twice a day. MGD treatment, so this is critical in my practice. I see so much MGD, and the 2 procedures that I most commonly do are thermal pulsation and intense pulse light therapy. There's a lot of studies in the literature about the LipiFlow thermal pulsation. It's a very effective treatment to unclog or unobstruct the Meibomian glands. Patients find it to be very easy to undergo. There's really no downtime. The IPL, on the other hand, is it's a light treatment, so it has a history in treating, cosmetically treating rosacea. And so the light is applied underneath the lower lid and across the cheeks and nose, and then we do a manual expression associated with that. And essentially, patients come once a month for 4 months, and after that, they have a maintenance treatment once every 6 months or so. So very effective. I like to, if patients have a more severe form of MGD, I pick the IPL as my first treatment. If they're only in that mild to moderate, I tend to pick the thermal pulsation as my primary treatment. I want to spend just a few minutes here on really something that's new and novel in dry eye. We've all heard of neurostimulation, so pacemakers, deep brain stimulators, TENS units, and so neurostimulation is not new to medicine, but it's certainly new to dry eye disease. The TruTear is the first neurostimulation device that was actually FDA approved in April of this year, and it's FDA approved to temporarily increase tear production. And so basically you can see from the image the device has 2 prongs. The device is placed into the nasal cavity, and the reason why it's going into the nasal cavity is that you can access the anterior ethmoid nerve there, and that's part of the cranial nerve 5. And so I didn't put that picture in there, but basically the pathway is that it goes through the ophthalmic branch of 5 up to the brainstem, and then the efferents come and innervate not only the lacrimal gland, I think this is interesting, but it also innervates the Meibomian glands and the goblet cells. So when in some of the more recent studies, these were presented actually at ARVO this year, the tear biochemistry was equivalent in the pre and post stimulated tear. So similar concentration of lipid and protein. And so you would think that if it was only doing aqueous production, that you would have diluted out all those proteins and it should be lower. But in fact, they didn't find that. There's increased, there's just as much protein and lipid. Therapies on the horizon, so there's a nerve growth factor, MMP-9, which induces mucin production. There's another company that's putting out a mucus-penetrating lotoprednol, so higher efficacy, less IOP issues. P321 is an epithelial sodium channel blocker that's going to prevent water loss, which is a completely novel pathway. And then the last one, which is really interesting, is lubricant. It's going to reduce ocular friction. It's actually a molecule that's found in our joints. And so there's lots that's happening in the dry eye space, and I think stay tuned, because even next year there's going to be more stuff that's out there. So with that, I want to thank you for attending. If anybody has questions, there's a mic up here. We'd be more than happy to take some questions. Question was, not a lot was said about punctal plugs. So I think punctal plugs definitely have a role in treating dry eye disease. So one of the things that I like about point-of-care testing is that, so if someone has a lot of inflammation on the surface of the eye, punctal plugs are not a good idea. And so I think it helps to, so if someone has abnormal tear chemistry, I'm less likely to plug them. For people that have kind of normalized ocular surface, so maybe I've started them on a course of steroids, or maybe I put them on Restasis or Lifitegrast, then I feel like then if they truly have a reduced tear film, if they have a low meniscus height, then I often will put them in punctal plugs. Chris, do you have anything?
Yeah, I think the exact same thing. Low tear meniscus height in Sjögren's or autoimmune conditions, certainly plugs make sense, but I do osmolarity and MMP-9 on everybody. If osmolarity is high, to me that suggests dry eye disease. If MMP-9 is low, it's dry eye disease without significant inflammation. Those people are perfect for plugs. Next question.
So the first question was comment on BluffX, and then the second question was which treatment? Oh, that's in the DEWS 2 report. The DEWS 2 report, he asked where is that list of treatment options. So if you go to the journal, The Ocular Surface, you can access it free online.
Yeah.
Chris, do you
use
BluffX?
As far as BluffX, I do use BluffX. BluffX, for those who don't know, BluffX is it looks like an electric toothbrush. The technical term is microblepharoexfoliation. Basically, it's a little rotating soft brush that's soaked in an antibacterial detergent solution, and you basically scrub the external lids and the lid margin and the Meibomian gland caps and you can debride basically the lid margins and remove any bacterial, what the company calls is a biofilm. There is some theory out there that the biofilm itself covers the ocular surface, covers the lid margin, covers the meibomian glands. It fosters bacterial virulence factors and what they call the quorum sensing, where the bacteria change their DNA to be more resistant. And so the theory is that that can lead to worsening dry eye over time, worsening not only meibomian gland dysfunction, but also aqueous production. And so the BlephX scrubs that. It's one of the really the only device that I can think of that actually mechanically debrides the surface. I actually combine that with, every time I do a lippy flow procedure, I do a BlephX in combination where I'll scrub the lids, the lashes, try to remove as much scurf, try to uncap the meibomian glands, and then do the lippy flow, which heats and thermally massages. I find that that's a good combination.
Other questions? Yeah, so the question is, somebody has they have symptoms of dry eye disease, but their oils look to be relatively clear. Is there a role for omega-3s, or would you go to more of a anti-inflammatory agent? I guess in that situation, I would give the patient the option. Starting a topical agent is not, I don't ever take that lightly, because it's a chronic medication if it works. And so if the oils are relatively thin already, you might not get as much of an effect. But remember, there are anti-inflammatory properties to using the omega-3s to treat the MGD or dry eye disease. And so even though the oils might look relatively thin, I think you still could get some benefit with the omega-3s. Other questions? So the question was about the amniotic cytokine extract. So that I use it in my patients that have kind of moderate or higher dry eye disease. It basically is made at a compounding pharmacy, the company's compounding pharmacy, and then we just send in a prescription. It gets sent to the patient over dry ice. They keep it in the freezer. They pull it out. It's 1 drop in the morning, 1 drop at night from that same vial. The one limit to it is cost. So it costs around $200 to $250 for a 1-month supply, so not inexpensive. But for those patients that have, keratitis, chronic inflammation, and you've tried several other therapies, it's actually been very, very helpful. Other questions? Yeah, come up to the mic. Pilocarpine. Okay. I don't use pilocarpine. The only people that I've seen on pilocarpine maybe have been put on it by the rheumatologist for their oral symptoms. Chris, do you have any pilocarpine experience?
No, I never use it. One, it's not FDA approved in the U.S. for dry eye specifically. There have been some studies and some companies, I think, that have tried secretagogues in general that just have never really worked here. I know in Japan and other places in the world that they are used with great success. Topical secretagogues, oral secretagogues, but we don't use it very commonly here in the U.S.
Do you have a question in the back? The question is, how long do you use the tetracycline, so doxy or minocycline? So I will give patients, if they want to try it, I give them a 3-month trial. And they have to take it for 3 months for us to really know if it's going to help them symptomatically. At that 3-month mark, then I kind of let them decide. So I have some patients that will do it every other day. I have some patients that will do it when they feel like their blepharitis is flaring. They might do it for a week. Chris, do you do anything different?
Yeah, similar. Yeah, I try to get them on the lowest dose that's effective and safe. It's a chronic, usually these are rosacea patients with pretty severe MGD blepharitis. And it's a chronic disorder, so you can't cure it, really. So usually these patients are on it at least 3 months, but usually a lot longer than that. And it really depends on how they're tolerating it, side effects. But I'll keep them on it.
The tolerability drives it.
What's that?
The tolerability.
Tolerability really drives it. Yeah, patient, if they like it, you stay on it.
Go. What's the difference between doxycycline and minocycline? It's basically, and they're both tetracyclines. They're just a derivative of one. I haven't noticed that minocycline was like way better than doxy. It's just what's available. So I consider them equivalent personally.
Yeah.
Anything else? Yeah, there's a question there. The question is topical steroids going to make the dry eye worse? No, I usually find the opposite for most of my dry eye patients. Now, there's a very small subset that maybe have a BAK allergy or something like that, where they're just sensitive and they can't tolerate a preserved topical medication. But in general, the steroids should suppress inflammation, should improve keratitis, should improve conjunctival staining. So for most of my dry eye patients actually would love to be on a steroid all year long, but of course that's not feasible. But in those cases where they're BAK sensitive or whatnot, you can order preservative-free dexamethasone from a compounding pharmacy if you really feel like they need that steroid. But often in that situation, I'm kind of moving on to, both Cyclosporine and Lifitegrast are preservative-free. Those are patients that I might do like thermal pulsation or IPL on, so that they're not having to be on a chronic medication if they're sensitive to medications. Yeah, go ahead. Any role for NSAIDs? I'm a cornea specialist by training, and so I see bad things that happen with NSAIDs. So there are different formulas of NSAIDs. So some have that guar gum, very thick. Other ones are like Prolensa, for example, are very thin. I rarely use NSAIDs, mostly because a lot of these patients get an epitheliopathy as part of chronic NSAID use. So I tend to avoid NSAIDs in general in dry eye. Chris, do you?
I do as well. I actually never use topical NSAIDs in dry eye. I'm old enough to remember the horrific melts that occurred back, 15, 20 years ago with generic Voltaren, the combination, and I don't think anybody's quite certain what the mechanism was, but I think it was a two-hit thing where you had an autoimmune condition, and then whatever was in this generic NSAID caused severe corneal stromal lysis and corneal melts. And that theory still exists even with on-label, non-generic NSAIDs topically. One of the risks is corneal epithelial breakdown. So I don't use it with dry eye patients. Yeah.
The question was, which topical steroid do you usually use?
Loteprednol is the one that I typically go to. The reason for that is that the safety profile is probably the best. It's what some people refer to as a soft steroid, even though it is very potent, and that's sort of a misnomer. It has the potency almost equivalent to prednisolone. That being said, the vehicle is very nice. It coats the ocular surface. There's a lot of immediate comfort from the drop. The potency is strong, but not too strong. You don't run into the IOP side effects that you see with, like, say, Durezol or prednisolone. Nonetheless, I still only use steroids usually for about 10 to 14 days at max when I'm treating the ocular surface, dry eye. A lot of times it's initiation with, say, starting Restasis or starting Xiidra, where you want to reduce inflammation as quickly as possible with the combination anti-inflammatory medications, steroid plus immunomodulator. But Loteprednol is my go-to. And I think most,
the only limitation for me is cost sometimes. It can be expensive, and if I'm only using it for induction therapy or for episodic dry eye, then I'm okay with prednisolone. Sometimes I use FML. So my choice is often cost-driven. We'll take our last question up here. Yes?
Do you have a magic bullet for the
Magic bullet for phyllotenure keratitis? Steroids for me. Steroids, but then those are the patients that I actually put on Doxy, because I think that chronic inflammation helps. You could consider like a topical azithromycin. It depends on what it's coming from. For most people, I think it's like either staph hypersensitivity or allergy or some kind of chronic irritation. But those are the patients, unfortunately, that you probably do need to pulse with steroids. Sometimes it's even a couple times a year, because you want to not have the cornea get scarred, and the KNV, the blood vessels that come in, sometimes they leak and they get lipid staining, and so. To me, the risk of steroids is a lot smaller than ruining the cornea. All right. Thank you all so much.
Thanks.